Okay, so they're my disclosures. So immunotherapy, this is the immunotherapy locomotive. It's a massive thing that's on the rails and it's going forward and we're all on it, whether we like it or not. This is the future for a lot of cancers. But as the person from the audience was asking, how can we move forward from what we've got at the moment where we have a lot of single agent immunotherapy trials? How are we going to move forward and combine these with other agents to get better results? So that's what I'm going to talk about. So first of all, this is the number of new immunotherapy trials on clinical trials per year, and as you can see, there's been a massive explosion in the number of studies. These are just any immunotherapy trials. Since about 2011, it's really taken off, and people like Winald and myself and other investigators are exhausted by the number of trials. Just before I came, I had 8 feasibilities. After ESMO and after ASCO, you sort of get these massive numbers of feasibilities, pretty well all immunotherapy trials in genitourinary cancers and other cancers. But the other thing that's taking off are the combination therapies, and there was a bit of a lag for about 4 years, but now these are all starting to take off, and most of the studies that we're doing now are combination therapies in various cancers. And why is that? How do we get there? So first of all, we have to understand the mechanism of immunosuppression in cancer. So this is the idiot's guide to immunotherapy, me being the idiot, not you people being the idiot. So I like to simplify things. And as we were talking about, it's a lot of it, not all of it, but a lot of it's around high mutational load. And as Winald said, there's in bladder cancer and lung cancer, there's environmental triggers, viral infections, tobacco, UV, radiation, etc., which lead to increased cancer initiation and increased mutational burden and develop these neoantigens. And then there's another stream, so it's not this external environment, there's these specific DNA repair mutations and mismatch repair mutations, BCR2, BCR1, etc., that also lead to this large mutational burden, creating neoantigens. So these neoantigens are like the honey pot to the bees being the T cells getting attracted to the tumour. And if the cancer produces checkpoint proteins, generally speaking, these tumours with high mutational burden do have the T cells in the tumour, and if there has been a mutation in the process, with many, many, many mutations, if the cancer checkpoint proteins get turned on, then the T cells get switched off, and then we give checkpoint inhibitors, switch it back on again. And that's how immunotherapy works, very simplistically. And as we know, there is this association between various cancers and tumour mutation. You've all seen this a million times, but this is my take on it. So there are some cancers over to the right there which are enriched with cancer types which are enriched with this high mutational burden. But there are these other cancers which, like prostate cancer, breast cancer, which aren't traditionally immunotherapy sensitive, but there is a subset of these patients who have this high mutational burden. These tend to be the patients with these DNA repair defect mutations, MSO high, and other mutations. So you can't always just depend on the tumour type to determine whether the cancer is going to respond to immunotherapy. So we do know that the hypermutated cancers respond to immunotherapy. So these patients with a high tumour mutational burden are more likely to respond. So let's say for melanoma, there's an increased survival if you've got a high mutational burden with ipilumimab. These are subset analyses of studies. So if you've got non-small cell lung cancer, if you've got a high tumour mutational burden, you get improved survival with just single agents, pembrolizumab, nivolumab, and with atezolizumab. And interestingly, the TMB, the tumour mutational burden, doesn't really respond to PD-L1 staining. And as these combinations come through, we'll probably find that the PD-L1 testing is going to go out of the picture, I think. And I'll show you why with some study results that we have. So those patients with just this generic high tumour mutational burden from external environmental issues, they have an increased response to immunotherapy, but also these specific things, so the DNA repair mutations, the patients with MMR deficiencies, they also have a high response to single-agent immunotherapy. So we've already spoken about that, but there is the other flip side of it, is some cancers just have these single mutations, single driver mutations, and this is a simplification, of course, but BRAF mutations, EGFR mutations, VHL in renal cell cancer. So just these driver mutations in just a few genes are causing the cancer. And these cancers have a less mutational burden, they have less inflammation, less neoantigen production, and PD-L1 may not be upregulated. So it's possible, if you would argue that the tumour mutation burden is going to be lower in these cancers and the immunotherapy be less effective, even in tumours that are thought to be immunosensitive. Is this the case? Well, it is. So the patients with BRAF mutant melanomas have a lower tumour mutation burden in melanoma and also in lung cancer. And patients with lung cancer with EGFR and ALK mutations have a lower mutational burden. So when you're talking about a lung cancer or a melanoma with a with a mutation, you're not really talking about these patients. You're actually talking about the patients who have got a low mutational burden. So they probably, you would think, have a lower response to immunotherapy, and they do. So this is the patients with EGFR mutant non-small cell lung cancer in the second-line setting. Multiple studies, 3 studies just summarised there, all showing that single-agent nivolumab, pembrolizumab, atezolizumab is no better than docetaxel in those patients with a driver mutation. In urothelial cancer, about 20 to 25% of these patients have an FGF driver mutation, single mutation. They tend not to have a high tumour mutation burden. The FGF receptor inhibitors seem to be effective, but the flip side of it is that they also seem to be immune insensitive. So the patients with the FGF3 mutations tend not to respond to immunotherapy. This is the general thought, but we have to get more information to see whether that's really true. What about melanoma? There is actually no real study of single-agent immunotherapy versus BRAF, so we don't really know the situation there. Now, the special situation of kidney cancer, I treat a lot of kidney cancer. That's not why it's special. It's special for other reasons. So, it does not fit into this category of high mutational burden, but we know for decades and decades that they do respond to immunotherapy. Why is that? And it's got to do with VHL and the VEGF, and there's an intimate relationship between VHL, PD-L1 and VEGF. So VEGF can switch on the immune system in many ways, but more specifically in renal cell cancer lines with VHL mutations, they have higher PD-L1 levels, and the PD-L1 decreases after VHL silencing. And there's other studies that suggest that PD-L1 is a direct HIF2 alpha or maybe a HIF1 alpha target. So renal cell cancer is not this thing with hypermutations everywhere and one of them actually makes the cancer immunosensitive. It's more of a very intimate relationship between the VHL being silenced in clear cell carcinoma leading to PD-L1 activation. And the same for Hodgkin's lymphoma. So classic Hodgkin's lymphoma, there's a translocation that occurs, and 90% of those, the PD-L1 and PD-L2 get switched on. So again, it is an inflammatory situation, Hodgkin's lymphoma, but again, there's an intimate relationship between the chromosomal translocation and PD-L1 getting switched on. Right, so that's the background for immunotherapy. It gives us a better understanding of how we should use combination therapy. So it makes sense that if you've got an immunotherapy sensitive cancer, high tumour burden, mismatch repair, etc., it makes sense to, if you want to improve on single agent therapy, to combine with another immunotherapy agent. Then the tumours that are immunosensitive but have these driver mutations, melanoma with BRAF, lung cancer with EGF, it makes sense to use an immunotherapy agent plus a specific targeted agent. And then we have these poor old tumours that we're struggling with, which are immune cold, and prostate cancer would be one of them. So consider an immunotherapy agent plus a non-immune agent. So if you've got a driver mutation, perhaps with a specific inhibitor, if there are no driver mutations identified, perhaps combined with chemotherapy or radiotherapy if the tumour is sensitive, or just combined with other neoantigen releasing therapy, which we'll talk about in a second. Now, let's talk about the easy ones. So tumours that are immunotherapy sensitive, listed there. All of these. So it makes sense to combine with IO plus IO. And of course, the promise, well, most likely these things are just going to be an additive rather than synergistic benefit. So the most famous IO-IO combination is ipi-nivo. Why was it used? So I must say there wasn't really a lot of translational evidence that went into leading to using that combination. Mostly it was used because Bristol Myers Squibb happened to make both drugs. In retrospect, you can always show why drugs work. But when you're actually going into it, often a lot of these combinations are empiric, and that's really, I'm not sure it's important to say, but it's important for us to realise. So, but ipi-nivo combination in metastatic melanoma is better than single agent immunotherapy. So the bottom line here is ipilumimab, and particularly in those patients who are BRAF mutant, it seems like the combination negates that negative driving effect, negative effect on the immune system of the driver mutation, and less so if you've got a wild type. But still, the combination, and just nivolumab by itself is better than ipilimumab. And this is looking at overall survival. So this is a lung cancer study looking at a very specific population. So it's a large, this is the Checkmate 227 study, looking at almost 3,000 patients, and there was various randomisations and stratification. But this is a pre-planned analysis, like a pre-planned post-hoc analysis, where they took out the groups that had a high tumour mutation burden. So that was actually 15% of the patients. And they said that, okay, we're going to do the study, and at the end of it, we're going to take out those patients with a high tumour mutational burden, and then we're going to look at those and look at the response of ipi-nivo versus chemotherapy. And that was published just recently in the New England Journal of Medicine. Very positive study. So this special subset of lung cancer with a high tumour burden, the combination of ipi-nivo, much more effective as far as progression-free survival, and the overall survival results are still awaited. Now we turn back to renal cell cancer. Again, the question of IO plus IO in renal cell cancer. So this is the Checkmate 214 study. Ipi-nivo versus sunitinib as the standard of therapy, first-line renal cell cancer. And as you probably all know, it's a positive study. Both co-primary endpoints met progression-free survival, and overall survival was better for the immunotherapy and nivolumab. But in a subset analysis, those patients with favourable risk, so they tend to have a lower tumour burden, surprisingly, well, maybe not surprisingly, I bet that this was going to be the case, and I was right. Sunitinib was actually better in these, and it's probable that these patients with low tumour load, not tumour burden, low tumour load, just not much cancer, it's probably the VEGF, which is the predominant pathway, rather than the immunotherapy, rather than the immune checkpoint issues. What about urothelial cancer? Again, talking about combinations of IO plus IO. Well, we don't really know yet, so this is just one of my patients who were treated with tremelimumab, a CTLA-4 inhibitor plus a PD-L1 inhibitor, durvalumab, showing a response. And we're waiting for so this study's finished. This is the Danube, single agent PD-L1 versus the combination versus chemotherapy, and I expect these results to be coming out soon. Other combinations, so we know about IDO, so anti-PD-1 upregulates IDO enzyme, and that produces this immunosuppressive situation. Theoretically, if you use an IDO enzyme inhibitor, you should reverse the anti-PD-1 resistance. There was a lot of, the other thing is the very, very low toxicity, and you can use it in combinations. And there was a number of studies all started in melanoma, lung cancer, bladder cancer, and the melanoma studies, which started first, at least for the Merck study, was negative. So Merck just canned all of their IDO studies. And I don't know about you, when I had about 6 or 7 patients on the study when the thing was canned. There's 300 patients on these studies, even in bladder cancer worldwide, and they're all still on the study, a study that's finished. We'll probably get some results out of it, but you won't get the primary endpoint. Some of the BMS studies are continuing. So another enzyme inhibitor we heard about yesterday. So adenosine, again, can cause an anti-inflammatory, anti-immune environment, and there are various enzyme inhibitors or antibodies to, say, CD73 that are in trial, and we're waiting. And there really are many combinations, and a lot of phase 1 studies and phase 2 studies looking at all these combinations. And all I can say at the moment is we just have to watch this space. Nothing's come out of those yet to move into any phase 3 studies, except the IDO, which was negative in melanoma. Okay, now, what about those tumours that have a driver mutation in an immune-sensitive cancer? And I've listed them there as examples, say BRAF in melanoma, EGF in lung cancer, etc. So it makes sense to combine the immunotherapy single agent with a targeted therapy. Okay, makes sense. So how do we go with that? Well, in this case, there was lots and lots of translational evidence to support the idea. I've just listed it all there, but just take it where there's lots and lots of evidence that if you use a targeted therapy plus immunotherapy, they should work better. There should be synergistic in this case. You should be synergistic, where you get more neoantigens being produced and you expect a greater than additive effect. So how do we go? So these are basically using combinations of EGFR receptors plus PD-L1 in lung cancer is too toxic. Not necessarily less effective. Some of these trials showed encouraging activity, but basically you just can't use the combinations together. Erlotinib and nivolumab, with durvalumab, gefitinib, and erlotinib and atezolizumab. So all those studies, they were either stopped prematurely or they were thought not to be, they're thought to be negative studies because the toxicity was too high. Similarly, in melanoma, if you combine a targeted therapy with ipilumimab, the toxicity is too high, so those studies have been canned and is not going ahead. The trials both abandoned. So, logical sense, lots of translational evidence to support it. Targeted therapy plus immunotherapy failed in lung cancer and melanoma, basically because of increased toxicity. So this is, the next study, this is melanoma. So this is looking at just good old-fashioned pembrolizumab with a combination targeted therapy, and this was just recently presented, I think, at ASCO. And again, a negative study, so it didn't meet its progression-free survival endpoint, but again, the toxicity was doubled. So for melanoma and lung cancer, the combinations of anti-PD-1 and targeted therapy so far have not going ahead, mostly because of increased toxicity. Back to renal cell cancer, the special cancer, the cancer that has intimate relationship between the targeted thing, which is VHL mutation, and PD-1, not hypermutated. What's the situation there? So this is the Javelin study, which is a combination of avelumab and axitinib, so immunotherapy plus a targeted agent versus sunitinib. Okay, just presented at ESMO. It's a positive study, so it met one of its co-primary endpoint, which is progression-free survival in the PD-L1 population. We're still waiting for overall survival, but so far the curves look good. But interestingly, it's not just in the PD-L1 positive, it was in all patients. Regardless of their PD-L1 activity, there was a benefit for progression-free survival. And we can see here that this combination is starting to overcome this issue of it works actually still in these patients who've got favourable risk. And it was that a furphy? No, it's not. So almost at the same time, just before ESMO, there was this press release. We haven't seen these details. A very similar study of pembrolizumab and axitinib versus sunitinib shows both an overall survival and a progression-free survival advantage. So again, in renal cell cancer, a combination of a targeted therapy, immunotherapy, seems to be working. And this is the third study. This is the Emotion 151. So looking at atezolizumab and a specific VEGF2 antibody, bevacizumab, So targeted therapy plus immunotherapy versus sunitinib, and again, a positive study, at least in their primary endpoint, which is progression-free survival in the PD-L1 setting, and again, we're waiting for the overall survival results. So what about, okay, move on now. So what about these chemotherapy-sensitive tumours that are also immune-sensitive? So again, a special population of cancer patients. Lung cancer, urothelial cancer, head and neck cancer, not talking about melanoma anymore. It just makes sense, doesn't it, to combine immunotherapy plus chemotherapy. And that's pretty well the foundation for these studies. It just makes sense. So immunotherapy works, chemotherapy works. There were a few combination trials to make sure it's safe. Minimal efficacy studies, not many phase 2 studies, but that's enough to say, let's just keep moving. We're going to do multiple phase 2, 3 studies of chemotherapy plus immunotherapy in various cancers. And, well, this is a fairly large phase 2 study showing it doesn't really matter, at least in lung cancer, which chemotherapy regimen you use. It's safe, and they all seem to be equally effective. And this sort of, it's not really a gamble, but this idea seemed to have worked. So this is the results of the atezo plus chemotherapy for lung cancer. So immunotherapy plus chemo versus chemotherapy alone, a progression-free and overall survival advantage. Tick. Extensive disease, and again, it seemed to be overcoming this issue. If you remember, we were talking about if you've got a driving mutation, this seems to be, makes the tumour less immune sensitive. So in this setting, at least, seems to be overcoming this issue of, it doesn't really matter whether you've got a mutation or not, you've still got the overall survival advantage. Small cell lung cancer, similar results, the survival advantage for the combination of chemo and atezolizumab. And there are multiple first-line metastatic studies underway, which some have finished recruitment, and we wait for the results. And again, in head and neck cancer, multiple studies of chemotherapy, and I just listed a few there. Chemotherapy with immunotherapy versus chemotherapy alone. Now back to the poor old immune insensitive cancers. So, I've just listed the big 3: breast cancer, prostate cancer, bowel cancer. Wouldn't it be great if we can get immunotherapy to work in that setting? And unfortunately, I don't really have any answers. All I can just talk about is this general push of using combinations of immunotherapy plus, a neoantigen releasing therapy. What is that? Anyway, anything that kills the cancer. And there's lots of translational evidence that, and Winald's talked about some of them, that you treat the cancer with something, any one of those, it releases neoantigens, and hopefully the immune cells come into the tumour and get switched on and start killing the cancer. So I'm doing a lot of these studies. They're all in the phase 1 setting. There are multiple, and I really don't get a feeling for any of them being particularly effective at this stage. We just have to wait and see. Except this study. So this is the enzalutamide plus pembrolizumab study by Steffi Graf. There was only 10 patients, and these are people who'd been on enzalutamide for prostate cancer, progressing. Pembrolizumab was added, and 3 out of 10 patients responded. In the end, one of those patients had microsatellite instability. But this study's triggered, and then almost in retrospect, they looked at, well, why did this happen? Why could it have happened? And there's some evidence that there's issues with enzalutamide resistance and circulating dendritic cells, and there is a theory as to why it's happened, but really not a lot of evidence has triggered multiple phase 1 studies in that setting using enzalutamide or abiraterone, radiotherapy, chemotherapy in prostate cancer with various immune agents. Okay, so in summary, the anti-PD-1 plus CTLA-4 combinations are effective in these. This is talking about these immune-sensitive tumours. So in other words, ipi-nivo is effective in melanoma, lung cancer with a high tumour burden, renal cell cancer. We're waiting for the urothelial cancer results. The other IO plus IO studies are awaited, multiple phase 1-2 studies, none really into the phase 3, except for the IDO, which was canned. And as far as the IO plus targeted therapy, great idea, but doesn't work for melanoma and lung cancer because it's too toxic, but it does work in renal cell cancer. Again, for those immune-sensitive tumours, IO plus chemotherapy does seem to be effective in lung cancer, small cell lung cancer. Again, we're waiting for urothelial cancer in head and neck. And the immune-sensitive tumours, there are multiple phase 1 and 2 studies underway of single-agent PD-1 plus something, and we wait the results. So back to the rationale of how these things are worked out. So you can either just say it's an empiric, in other words, sounds like a good idea, ipi-nivo, IO plus chemotherapy, or enzalutamide and IO. They're examples of, we've got these drugs, they work, let's just put them together. Or you can do lots of translational-based research to logically determine a combination, such as targeted therapy plus IO, or either IO combinations, PARP plus IO. So unfortunately at the moment, the one that's winning is the empiric. It's just going forward and saying, I think this is a good idea. Now that's not to say that we should not, of course, not, this is about as far as we can go, I think, with the current combinations is with the empiric ones. It just sounds like a great idea. To get things moving further, we really do need more translational evidence and looking at the patients who are on our current studies to see whether we can move, particularly those patients who have immune cold tumours, prostate cancer, bowel cancer, breast cancer, moving those patients into the immune era. So with that, I will finish and thank you.